Is die link ergens gestuurd?
Ja, je kan hem ook, hij staat daar invitation URL.
Ja.
Daar staat hij.
Ja.
En hij staat ook op de...
Nog iets voor je meenemen, Herco?
Glaasje water dan graag.
Waar staat hij nog meer?
Ja, op Baby Connect website,
Oh,
nieuws
oké.
en dan online workshops.
9:55.
Nee, ik zie geen link.
Zoom.us. Wacht even, ik zal even deze afsluiten. Die heb ik nou niet nodig.
Zoom.us
US.
slash en dan
6464.
nee, er iets tussen.
J. Sorry. J.
Slash J
Slash 6464.
6464
11833.
33. File, moet toch iets download lijken.
een online workshop.
Je zit in een online.
Ja.
Wist je dat al?
Nou, ja, die stond op het programma voor 9:30 en dat is het bijna.
Maar is er een
12 uur.
nee, waar gaat
Oh, wacht, sorry, waar gaat het over? Sorry,
het?
dit is een online workshop van de Digital Health Society. En die gaat over connecting the dots in maternity en babycare.
Dat is leuk.
Ja,
Ik kreeg een hele vage mail van iemand die zegt van ja, jij hebt ook zo dat ik kan sparren over diverse vage dingen. Dat ik dacht, nou, ik weet niet wat voor die ze hadden het allemaal kunnen denken. Of je hebt
contant hebben. Gaat niet goed. Zouden ze mij nu aan de andere kant kunnen horen?
nou niet.
Mute. 15 participants, maar ik hoor geen piemel. Ik hoor helemaal niets. Het gaat vast niet goed. 16 participants. Als het interessant begint te worden, roep ik je erbij.
Good morning.
Hoor.
Okay. Good morning, everyone. You can see me and can you hear me? I'm at the on the screen. I have muted everyone, but everyone can unmute themselves. So if you are want to join in, please click unmute, or you can also add your own video stream to the stream. Welcome to the Digital Health Society Task Force 1 online workshop called Connecting the Dots in Maternity and Baby Care. Welcome everybody. My name is Herke Commons and I am the host this morning for this session, and I will guide you through these presentations and the discussion afterwards. And first I want to show you the program. I think I need to move that. First, I want to guide you through the program. So we have the opening and welcome that I just did, and we'll explain some more why we have this workshop. Then we'll do a short round of introductions with everybody. Then we have 3 presentations making the case on interoperability for baby and maternity care. And then we move on to the discussion part where we explore the common ground and challenges that we have. And well, eventually we need to get some things done. So then we'll discuss the next steps. So where do we come from and where are we going? Let me see if I can change that. Yeah. Sorry. Where do we come from and where are we going? The Digital Health Society is an open cross ecosystem platform where everybody who is working on better healthcare is working together on making sure that the information can be shared throughout the healthcare systems. It started in 2017 when during the Maltese EU presidency and their eHealth Week, where the Estonians who were at the next EU presidency held a session on whether or not we want to come together as different countries and different organizations in creating a community of like-minded people working together on solving the biggest challenges in interoperability, basically, or in getting the right information in the right place. And from there, it took off with the Estonian presidency. And during their presidency and their conference that they held in Tallinn, the Digital Health Society was launched with 5 task forces. And one of the task forces is aimed at the one of the basic requirements of being able to share data digitally between healthcare systems, and that is interoperability. And the Dutch Ministry of Health is already working hard on enabling electronic health data to flow safely and securely throughout the Dutch healthcare system. But we also realize that interoperability doesn't stop at our national boundaries. So it's across borders. And that is why Erik Gerritsen, the Secretary General of the Ministry of Health, and who is a passionate digital health advocate himself, is leading this task force on interoperability as an ecosystem effort to improve meaningful digital communication between healthcare systems and patient systems. And to take meaningful steps forward, we found that we need to focus on not the coalitions of the willing, but the coalitions of the doing, the people who have working solutions and who are willing to be the real leaders in their fields. And today, we do just that. We're going to focus on electronic communication in maternity and baby care. And we do that for several reasons. One of the reasons is that it's a very recognizable and human part of healthcare. So it's not very technical, and almost everybody can relate to maternity and baby care. And one of the other things that make it important, and why we chose this topic, is that we see a lot of progress being made in this area that deserves this to be in the spotlight. And thirdly, I think it is it has a relatively limited scope, but it is a place where everything comes together. So all the stakeholders come together in this this relatively short period of time, with a lot of challenges in interoperability and digital communication that are exemplary for other sectors in healthcare as well. So it's a very holistic, it has a very holistic approach, and that is why it's also very interesting to learn from that, to see what we can use in other systems and in other places as well. So I am honored to, and very pleased today to share with you some of the best examples that are out there and who will be presenting today. But first, I have some public service announcements. The first one is that this session is being recorded. So if you don't want to be part of the recording, don't use your video stream. So block your video stream. You can also mute yourself, and you can use the chat function to participate. That's one. The other one, that's the bridge to the other one. It's a general recommendation to everyone. If you have questions during the presentations, please use the chat box. After the presentations, we'll have time for discussions and questions. But if you use the chat box, people can already respond to that. And we have a list of all these questions. And if we don't address them in this session, we can address them later on, because we have the record of those questions. And it's a very good way to interact with everyone. So there's different options for the chat box. You can ask questions to everyone, and you can ask questions to people directly. And I recommend, if you want to share your contact details, you do that as focused as possible. So contact the people directly. But if you want, you can also use that for everyone. And we use Zoom as a platform for this session, and it has a very interesting feature that is the annotate feature. And it depends on which system you are using Zoom on, but you can use the annotate feature to well, to draw on the shared screen that we have. And if you annotate, you can, like I'm doing here, you can add all kinds of things to the screen, and you can share those with the screen. You can draw. Those hearts are stamps, and you have different icons for that. You can also use text, and I can save everyone's contributions, and afterwards use those as images in the report that we will send everybody who participated. So we can save and share everyone's contribution. And I would like to use that now to, let's stop annotating and clear my images. Yep. I want to use that now to do the round of introductions, and I want to use the annotate version, the annotate for that you can draw on the screen where you're located. Yeah, it's as simple as that. So use the annotate feature and stamp or draw or be as creative as you want. You can make arrows or so who's out there in the Mediterranean? Is that a mistake, or is that someone actually on a boat out there on a holiday, perhaps? Yeah.
No, I'm out in the Atlantic. I've just put my name in the Atlantic, but I'm in Cork.
Yes, many Dutch people.
It's Mandy from the northwest coast. I can't get it to work. So.
And Valentina is in Barcelona, I think. And Frederica is somewhere in the Mediterranean as well.
Both in Barcelona, actually, yes.
Okay, thank you. I'm going to save this now. And then I'm going to clear the drawings. Ooh. Oh, of course, I still have my own annotate on. So now using the chat version. So please use the chat and send to everyone. And I would like to know why you are here, not just specifically in this session, but why you are in this field of digital health in maternity and baby care. Thank you all. I think we can keep the discussions going in the chat. So there's no need to clear this, but the chat is still going on for everyone. And now I think it's time to start with the first presentations. I'll clear the annotations that are in there.
Yeah.
And so I would like to invite the Baby Connect team to come with their presentation. And I think I have it here. I know I have it here.
Chat weer.
Dit is PowerPoint. Waarom heeft hij niet gewoon op vol scherm? Ja, nee, ik heb hem.
Gooi ik hem dan op, hoor.
Jij komt hier zitten?
Ja.
Die. Oké.
Okay. Thank you, Herco. Can you hear me also through the microphone right now? Because I cannot test it here. Yeah, yep. It's okay. Okay, thank you. I'm honored that we can present something and share with you information about the program Baby Connect. We are happy to share this information with you and to hear from other programs as well, and to talk about questions that are there and challenges. First of all, I introduce in general a little bit about the Baby Connect program, and then with the layers of the interoperability the interoperability model that we use in Europe and in the Netherlands, we also would talk about different aspects of the program and the way we work with that. I first have to do one more technical thing. Erko, can we skip this because it's blocking something here? Yeah. Okay. Yeah. Thank you very much. Okay. So the program Baby Connect. One of the things that needs to be very, very clear, it's a program to facilitate implementation of data exchange within the perinatal healthcare field in the Netherlands. It's not a product. It is really a program wherein we cooperate with many actors in the field to make sure that in 4 years' time we achieve our goals when it comes to data exchange. It's a program that is financed by the Ministry of Health, and we're very happy that actually now we are on the beginning of this program, because the program runs from 2019 until 2022. But in the years in the past, a lot of things have been done to prepare us for these implementations. Well, when it comes to perinatal healthcare in the Netherlands and this program, our scope runs from the moment of the conception consult until 8 weeks postpartum after the woman has given birth. In this slide, there is also some facts and figures about the perinatal healthcare in the Netherlands. We won't go through them in detail right now, but if you're interested, you can read a little bit about it. And there are some characteristics for the situation in the Netherlands, what many people probably will know when it comes to home birth and how it's organized, with also many primary midwifery care that is in place. And it brings us also to a little bit of the complexity, because many different healthcare professionals are involved also in many different organizations. So when it comes to actors and organizations who are involved, first of all, the pregnant lady herself, or the woman who just gave birth. And she is surrounded by many healthcare professionals that are providing perinatal healthcare. And in the Netherlands, as I said, there are primary midwives working in this field, but also, of course, the hospital care is there, and the maternity care is many times provided in the home situation, organized in maternity care organizations that are most of the time nationally organized, while the other actors most of the time are working more on a regional level. So fortunately, in the Netherlands, there is a lot of cooperation between those different healthcare professionals. There are 76 perinatal collaborative alliances in place where gynecologists, midwives, maternity care health providers are working together. But of course, all those healthcare professionals are also organized in branch organizations, professional organizations that also play a role in when it comes to all these developments. And over 25 different software applications or products or services, suppliers of services we are dealing with when it comes to these developments. And besides that, from government, other entities, other organizations, other programs are already working in this field when it comes to developing more interoperability and data exchange in the healthcare throughout all the sectors. And of course, we have to make sure that we work with these programs and entities as well. So in the program Baby Connect, I think everybody understands that communication is really key. We have to work with many, many people that needs to be informed and also contribute, will contribute to these developments. Well, what are the targets for the program Baby Connect in 4 years' time? We have to make sure that the implementation of integral and interoperable solutions for perinatal healthcare are there when it comes to data exchange, and also that all patients and clients have their own PHR, the personal health records, and that they are actually the focus and in the center of how we will develop all these things. Data sharing between patients and professionals and between professionals among themselves must be possible then, and also the data must be available for secondary use of data when it comes to for management or for research purposes. So we have to make a transition from the current to the future situation. And the current way of working is a source for huge motivation to change, because facts on paper are in many cases still the norm for sharing of information, and that has a lot of negative effects. And we want to create a situation where data will be on time and will be complete, and the relevant data will be there and reliable and also in a structured way presented or available for everybody that needs the data. And that it's, as I said, available for both patients and professionals, of course. To accomplish this, we need interoperability. That is one of the most essential things, as we all do, as also is needed in the other programs throughout Europe. And there is a model of interoperability in Europe, but it has been evolving. We see here the 4 layers: the legal interoperability on organizational level, semantic and technical. But there is already a refined interoperability model where we go from 4 to 6 layers, where legal, privacy, security, organizational, care process, the information, applications, and IT infrastructure are in place. And a very important thing is that the primary process is here more explicitly in place, and that is also very essential for the approach that we use for Baby Connect. Because what we said, patient or the client is in the center. That's where our main focus is, and she is one of the end users when it comes to data. And after that, also the individual healthcare professionals are very important end users. There are more groups than that. There are also the healthcare providing organizations that are data consumers, and then are the secondary data users as well when it comes when it is about research, and if it comes to national registration for benchmarking, and also other national organizations are in need of data. What we see is that those 4 groups have different needs and wishes when it comes to the way data sharing is being implemented. What we see as a very important thing is to start with implementing data sharing in the primary health process. And that means that we will focus, first of all, on these two groups, because they are involved in day-to-day life in the primary healthcare process. And after that, of course, in the coming years, we also have to make sure that the health providing organizations and the last group also will be serviced when it comes to data sharing. But we focus, first of all, on the primary healthcare process. And what we do in the approach in the program of Baby Connect is that we involve these end users, all 4 groups, very intensively when it comes to the design and the development and the implementation of the solutions. And it's a very important thing, because we know for a fact if we don't do that, then the end users in the end will avoid working with the solution that is being implemented. So therefore, we organize end user groups on a national level to make sure that they are involved and that they really design the solutions in the way they want to use it. Because otherwise, this is not in the ICT situation, but it's another example of how people in day-to-day life will avoid that is what is developed if it's not done in their way of daily use. So what we do, we organize meetings with end users, and they talk about the healthcare process they are working in or that they are part of as a patient or a client. And we talk with them about what kind of data they need on what moments. And so we have these sessions, and they actually work with building blocks of data to together structure the different data sets that they need on different moments in the process. And so that is the way we are building right now or developing right now the specifications for actually the data screens of the screens of information they need to see actually you can call it a dynamic view of data that they need. But to make that possible, of course, on the different levels of the interoperability model, we need standards to make sure that we can connect all these different actors together when it comes on all the different levels. And for security and privacy of the interoperability model, in the Netherlands, these standards are being used. You see them all here. When we share it, we'll make sure all slides actually are already translated, but this is an exception I see right now. But we'll make sure if we share it that also this slide will be translated. Well, we won't go through them in detail right now because of the time. When it comes to the primary process, there are already standards in the Netherlands for improving the quality of care that are very, very relevant. For perinatal healthcare in the Netherlands, the care standard integrated perinatal care has been developed and in place, and also now mandatory for all the different kind of healthcare professionals that are involved in this field. So there are quite some standards already there, and maybe on the bottom might be interesting that also when it comes to working with quality outcome indicators, a lot of work is being done right now to work also with ICHOM and to introduce that. There are also standards in place when it comes to semantic interoperability and also on a technical level. So what you see here, maybe what I can mention explicitly is that working with SNOMED and LOINC is a very essential key for us. And also in the technical interoperability, there are standards being developed in the Netherlands as well. So there's quite some information what you can read also afterwards. And if there are questions about it, on around the table here, right now in The Hague, there are quite some experts involved that can answer questions about this, maybe already in this session, but maybe also afterwards. So please make sure that you contact if you are interested. Then a little bit about the architecture approach in the program Baby Connect. When we want to share information, there's of course the need to link between two systems to be able to do that. And we talk about the source of data and we talk about consumers of data. And what we know is there are many, many sources and many, many different kind of consumers. That is one of the things that are making it quite complex, of course. And what you see here is the source has to generate output that is structured and sent in a way that is compliant to all the standards, making sure there's safe transport, and the data consumers must receive and read this data also in a way that is structured and making sure that the consumer can see it in a way that she or he needs it. But there is a risk there. I will come to that later. What the wish is that people can read information from many, many different sources on different moments. Both the client patient wants to do that and also the professional. And well, there are different techniques to do that. There are different topologies to link systems. So here there are some different examples. And what we see in many cases that we are having invested a lot of time and effort to make sure that actually the mesh topology is in place. And what our conclusion actually is that this is a situation that is going to be very, very difficult to achieve in the end. So we had to make sure that to find one of the topologies that will be more practical for us. Because linking between systems also creates some risks there. Because when data cannot be generated in the right way, or the transportation is not safe, or the data consumer cannot read the data, and this is in many cases still the case, we have a problem. So this was one of the challenges for in the last years when it came to preparing for this program, how to do this. So because of the mass topology, many different systems have to communicate in a certain way and to make sure that all the systems are linked together. So then, and actually we think that this is going to be sort of an utopia. So what we chose is to go from this mesh topology to the star topology and work with registries. And in this register, metadata is being stored about where the data of an individual can be found. This is the essential part of the architecture that we are working with. So what is being done as well, if there are problems when it comes to how data is being presented and being made available when it comes to the formats that are being used, one of the things that we introduced and what we saw, of course, in other sectors and in different areas where things like this were developed, is to introduce something like the mapping and translation between the source and the register to make sure that everything is available in the right formats and in the right structured way. And also on the other side, when the data consumer collects, queries the register to collect data for him or her, then also mapping and translation is needed to make sure that it is available in a structured way. So the data consumer can query the information and get it presented in a readable format. And that can be used, for instance, in a dynamic viewer. In that way, we are less dependent on data software suppliers to change and to develop things in such a way and also time-wise in time to make sure that implementation is being possible. So here is actually the somewhat simplified representation of the architecture that will be used in the program Baby Connect. And a very important aspect as well is that more on an organizational level, the registries with metadata will and can be controlled and guarded by regional organizations that explicitly are non-commercial or not-for-profit organizations that will do that. Also guarding, of course, that only those people can get access and systems can have access when the patient client has given her permission, there is consent about data sharing, and only then data can be retrieved, of course. So that was in brief some of the characteristics of the program Baby Connect and the way we are approaching this. The point where we're standing right now is that we have had a proof of concept already a few years ago. We had a pilot projects in the last year, and all the specifications are being made now, and the standards are more specified and completed in the coming months, and then we will be ready to start implementing in several regions and to make sure that also in live situations this can be used. And of course, still facing many challenges. One of the things is when standardization is not complete yet, or completely accepted or published, or not yet built in different applications, how still to make sure that we can make progress. And for that, we are very happy that together with all the experts in the country, we see possibilities to put these in-between steps when it comes to mapping and translation, so that we can develop fast enough for what we want to achieve in the coming years. So thank you so far for listening and for your attention. And there probably are questions there. That's a very interesting question, Nick. Thank you very much. What about the more social factors and change management? Well, actually, I think at least, now maybe I exaggerate, but maybe almost half of the time and effort and energy is about social factors and change management. The technical part is, of course, a big challenge, but when it comes to mobilizing people and getting them together and all the different activities that are there and experts that are already have been working in this field for so many years to come together and to create one strategy to approach this. So that is what we're doing. Okay, and also the question that especially Dutch maternity care. So the period after when the baby is born, that there are still a lot of problem of integrating systems. That's true, and still a lot of work even is not being done within with computer software, but all with pen and paper. So there are huge challenges in that field as well. But also all the professional organization and branch organization, we need them for that, because then we talk about all the different applications that all the different healthcare professionals are using right now. But I think so far for now, if I look at the clock, my 20 minutes are gone. So Herco, back to you.
Okay, thank you very much. I will now go to the next presentation. Let me see if I can open it up. The next presentation is from Liz Ashell-Payne from ORCA. And Liz, if you could share your screen with us and unmute yourself.
I will do.
Or do you want me to?
Can you hear me now, Echo?
Let me see.
Can you hear me?
Stopping the share. Yeah, there she is.
Fabulous.
But I think you're still muted because we can't hear you.
Okay. Let's have a quick look. It says that my audio is on. Can you hear me?
Yes, we can hear you.
Fabulous. Herco, can you hear me? Oh no. Yes, I am. I'm going to share my screen now. There we go. So Herco, can you hear? I think you've muted yourself now, Herco.
Yes, I can hear you.
Fabulous. Are you happy for me to start?
Yes, please.
Okay, so thank you so much, and thank you so much for inviting me here today. And actually, that last question was really helpful because the way in which we have at ORCA looked at driving interoperability of health apps into maternity and baby care pathways is by starting with the change and the engagement of patients, professionals and healthcare systems. So I think what's really nice is that this presentation should hopefully be really complementary to the one that you've just heard. So my name is Liz Ashell-Payne and I am the Chief Exec and co-founder of ORCA. ORCA stands for the Organisation for the Review of Care and Health Applications, and our mission is to distribute and activate people, patients and professionals to be able to search for and find the best products for themselves, their families, or their patients. And our mission with regard to interoperability of health apps is to achieve a way of interoperating great health apps at scale, rather than doing the work on a per app basis. So because I'm obviously going to talk about health app integration at scale, what I wanted to do was just start with what the size of the opportunity is, and drill that down into maternity and baby care. So you probably already know that there are lots and lots of health apps available to us. Some of these figures have actually changed just in the recent weeks. So we currently have over 347,000 health and fitness apps across our app stores, and every day 5 million people download health apps. What's really interesting of that population who are downloading health apps is that by a significant amount, the most people who are downloading health apps are women aged between 20 and 35, and the highest downloaded health app is a period tracker. And that's because when women start to think about their own health, it's normally when they're starting to think about getting pregnant. So what's really exciting about this agenda is that we're already knocking on an open door. Women are already using health apps to either help themselves get pregnant, or to manage a pregnancy, or to support their children's health. What's also really interesting is there is a growing interest from our health and professional communities, where over 93% believe that apps could help their patients if they knew which app to recommend. And a lot of that, again, is driven by the women themselves, particularly in maternity pathways, because they're turning up to clinics to talk to their healthcare professionals, bringing their phone with them and the apps that they've downloaded. So we're seeing this groundswell of people being interested and wanting to use health apps. Okay, if we drill down a little bit more into some of that data, I'll just move Heiko's picture there. What we can see is that in the in this marketplace, what we've seen is an increase in health apps that are focused on health condition management, and you can see there the increase has been quite significant since 2015 to 2017, and 9% of the apps within health condition management are focused on women's health and pregnancy. If we drill down a little bit more into the opportunity of health apps in this area, what you can see is that there are currently 4,650 health apps available to women to support their health specifically, that are being looked after. So you'll see there that I've placed a small wording afterwards, and that's because there are more than 4,650 apps available to us, but not all of them are being maintained. So these are the live apps that are available to women, and you can see that about half of those apps are actually, in fact it's more than half, apologies, more than 2/3 are focused on pregnancy. So there is a huge number of health apps available to support women's health. So if we've got this huge opportunity where women are using health apps, where healthcare professionals think they could support their patients' care and the pathway, what are the major blockers? Well, there are 4 big ones. There are other blockers as well, but the 4 big blockers in the first instance is, first and foremost, awareness. People, patients, professionals actually don't know yet that these solutions exist. And if they're not aware of these products, then they're not going to search and find them. If they do become aware of the opportunity, the second problem is access. Where do you go to find these apps? So just looking at the slide previous, if you wanted to find the 3,280 pregnancy apps, you're going to struggle, because unfortunately the health app stores on Apple and Google just don't work. So if you type in pregnancy, you're very likely going to get a small selection, and that small selection will not be based on quality. Which brings me on to the ultimate barrier. Digital health is absolutely critical in how we work as health and care systems moving forward, but the big barrier is trust. People, patients, professionals do not know whether they can trust these products, and that's really difficult. So, and also it's not unfounded, because unfortunately out of that 4,500 apps available, only 15% of those apps will meet the standards that we've just been listening to. And in order for us to gain trust, we need to be able to inform people and empower them in knowing which apps are safe and of high quality so that they will use them. And then the fourth barrier is governance. If we start to embed health apps into maternity pathways and childcare, how do we govern this ever-changing landscape? Because apps change all the time, and that's what we want them to do. We want them to be responsive to the ever-changing requirements of our population needs and requests. But with that ever-changing landscape comes a real challenge of how do we govern and manage risk as the app updates and changes. So what we've been doing at Orca is we've been working to break down those barriers, and we work across a whole range of different pathways, but specifically across maternity and children's care, we have been working with across Cheshire and Merseyside, which is in the northwest part of England, which covers 27 NHS organisations. And it's a partnership called Improving Me, and it's one of the national Vanguard New Care Model initiatives and one of the 7 maternity pioneers in the country here in England. Now, this partnership's aim is to improve the experience of women and children. And the focus was about improving the service areas of maternity, gynecology, paediatrics and neonatal. And their aims for this programme was to provide safe, high-quality services, reduce variation, deliver excellent experiences, and support individuals in being able to prioritise their own health and well-being by adopting facilitative and enabling approaches. And the way in which Cheshire and Merseyside wanted to support that was through a digital offering.
Picked it up.
Apologies, is there a question? No? Okay. The way in which Cheshire and Merseyside wanted to work was to provide access to safe, high-quality digital health solutions that would enable and empower the women to be able to look after their own health and well-being and support the well-being and health of their child or children. Now, what that starts with from a perspective of knowing which products are high quality and safe is a review of health apps. And so what we did with Cheshire and Merseyside Vanguard was we first of all did a huge amount of work to look at those health apps that were available. And the way in which we know what that data looks like is because every week we take a data scrape from Google Play and the Apple App Store, and we draw in all the information globally around what apps are available to us in different clinical areas. Now, the first thing, as I mentioned before, is we apply a did not qualify filter, which gets rid of apps that are not being looked or maintained, and this gets rid of 2/3 of all health apps. So that number of about 4,500 is actually tripled when you look at the number of apps available, but most 2/3 of those apps are not being looked after. And if they're not being looked after technically, i.e. they're not being updated, then what that tells us is that data security will be compromised, and it's also a proxy to indicate that that app is not being looked after clinically. Once we've curated those apps into 260 categories and we've worked out how many apps there are in each of those different areas, as I showed you earlier on, we now know which apps we need to process through our review engine. Very briefly, the way in which we do that, because otherwise you'll have lots and lots of questions, is we first of all classify the product. So not all apps are the same, not all apps in maternity and children's health are the same. Some apps are very simple and a level 0. These might be apps, for example, very much focused on health, mindfulness. So an app that plays you music for mindfulness would be a level 0 simple well-being. And at the other end of the spectrum, you have apps that are regulated medical devices that might already interoperate with clinical data sets, and therefore we need to assess the different classifications of apps in a very different way. What we also then do is work out, well, what does the app do? Does the app give the lady education information? Does it help her to self-monitor? Does it link to social networks, etc., etc.? And a combination of those two things helps us to work out which of the 2,500 standards, regulations and best practice need to be applied to that product. So we heard in the earlier presentation a number of data security standards that are already available, but there are a whole host of other standards that we would need to assess an app against around clinical validity, academic robustness, user design, information governance, etc., etc. So once we know what the app is from a complexity point of view and what it's trying to do, we then apply all the relevant standards around data security, data safety, clinical validity, user experience and user feedback. And the first thing to say here is, only 10 to 15% of all health apps that we review meet the quality threshold that we would expect. But that isn't because the app developers don't want to create good products. That's because it's really complicated. There are a lot of standards out there and the standards are ever changing. So what we do is we contact the developer and we provide them with an improvement report that tells them how to improve their product so that it can be the best that it can be. Because if we're thinking about interoperating with health apps at scale, we need to make sure that when the information either is pushed or pulled from a product, that it remains safe. And so we need to make sure that the app developers know at scale how to make sure that their product is providing that quality. Now, what we then do is once we've got the information about whether the app is good and safe and able to be identified to women, what we then did with Cheshire and Merseyside was we then created a journey to integrating mHealth apps into care. Now, the first step on this journey was very relevant to the last question that we had, and we've worked from a bottom-up perspective where what we wanted to do was integrate digital health apps into the offer for women by activating them to know which apps are safe and know which they should use. We then wanted to support the clinical integration of health apps into pathways using transformational change approaches, looking at redesigning care pathways and really thinking through where would digital health offer a benefit and a better health outcome for the women and their children. The third area is really helping them to get the most benefit. We then wanted to be able to watch which apps were being used by when, for whom, and then work towards interoperability. So what do we do? Well, the first thing that we did was we created the Improving Me partnership with a health app library. And this health app library is promoted to women at point of them alerting a healthcare professional to being pregnant. It is promoted in places where women go, so in children's centres, in GP surgeries, but it's also promoted in areas like cafes and baby groups. And what this health app library enables the women to do is search for and find good health apps to help their health and their children's health. Following this launch of a health app library, what we then did was, because the Improving Me program was creating a digital health hub, was we integrated the apps into that digital health hub. So you can see this is one page of a hub which has huge amounts of information about what services are available, information, education, and now also health apps. So preconception, early childhood, breastfeeding and pregnancy. And these were chosen because of the previous work that we'd done on the health app library. We knew which apps and which areas were being most searched for by the women. This is obviously all about the women having the opportunity to search for and find good solutions independently. But what we also did was we worked with the healthcare professionals who had the touch points with the women and enabled them to embed health apps along the care pathway. We provided them with the ability to recommend, or let's be brave and say the word prescribe, a health app to the women at those touch points. What we saw was every time a healthcare professional, and those healthcare professionals that we worked with were predominantly primary care, so GPs, midwives, health visitors, was that every time a health app was recommended, which happens via text message or email, that the women were 71% likely to download the app. And so the act of recommending an app from a healthcare professional to a lady really activated the woman to feel that they would use that product. And obviously the healthcare professional was able to trust the product because they knew it had gone through a review process. And because the app has been prescribed through the system, if we find an error with the app, because one of the things that our review process does is when we get the data scrape on a week-to-week basis, it alerts us of any changes to any product that we've reviewed already. If there's been a change, we will re-review it. If that re-review identifies a new risk, we will do a recall of any apps that have been recommended to patients, and so the governance is established. You can see there a little quote from a GP who said that it was just a no-brainer. It provided the practice with the ability to find the best apps to meet a person's health need. And that's been phenomenal. That has been absolutely critical in supporting people to use good health apps. We also spent a long time training and educating the healthcare professionals. The training and education is really important. Unfortunately, very few healthcare professionals are trained in digital health as part of their professional training. So we support that by educating and training the GPs, midwives and health visitors to understand more about the digital health opportunity, how to find apps, how to match apps to the patient's need. And this is really important because one app won't meet everybody's need. You may have a woman who's pregnant who's also got diabetes. You may have a lady who's pregnant and also struggling with alcohol abuse, for example. And as such, different women will need a different suite of products. The training also enabled them to compare similar apps, recommend apps, and look at the feedback and reporting from the women based on use of apps. Now, as I said, this is a journey. Now, the interoperability piece is the next stage, and the work that we're doing now is not just with Cheshire and Merseyside, but with a whole host of other partners, including organisations like NHS Digital, but also further and wider across Europe. And that work is now around setting new standards that we can apply to products to enable interoperability to happen at scale with health apps. Those new standards are looking at consent. So the consent piece is absolutely critical. How do we gain consent from women to be able to have them share data? And we've done a big piece of work. I know that the North West Coast Innovation Agency is on the call today with the North West Coast Innovation Agency to look at what that would look like at point of use, because although consent seems very simple, actually going through the process is quite laborious and would absolutely kill any kind of user experience. So again, we started with the end in mind and built a mock-up of what a consent protocol could look like, and we've been testing that with end users and healthcare professionals. The other areas around standards include authentication and verification. And again, we've been working with patients, professionals, developers, and the buyers to find a solution to achieving delivery of these standards in a way that means that user experience is not massively compromised so that people will use it, but that it also assures people that consent, authentication, and verification have happened. Now, the other piece of work is now, as we move forward in this project, we know which apps are being most used by women, which apps are being most recommended by healthcare professionals. And so we now have a short list of health apps which that community are very keen to use. And what we're doing is now contacting those developers to invite them to open up their API, so that what we're first and foremost able to understand is not just whether a lady has downloaded the app, but also how frequently they use the product over what period of time. The next stage on from that is then obviously opening up the data, the health data from within the app, and drawing it into the clinical system environment. And so we're working with a number of system vendors to ensure that that can happen in a safe, reliable way. So what's next is there's lots and lots of dots that need to be joined together. So thank you very much for listening to me, and I'm happy to take any questions.
Demuten. Gelijk. Thank you. Thank you very much, Liz, for this wonderful presentation. I see some questions about HL7.
Yes, yes. Yes, so HL7 is one of the standards that we would apply to a product, but as I mentioned, not all health apps wish or aspire to integrate into clinical environments. So so thank you very much for the link, but we do apply that to health apps that are relevant to that standard, along with literally hundreds of others. And the interesting thing about the standards is that what we're seeing is a unity of standards, not just in an English jurisdiction, but also in a European environment. And HL7 forms part of that.
Sorry about that. I needed to unmute myself again. One of the things that is really taking off in this field is the use of the HL7 FHIR profiles and to connect consumer apps more to the clinical world. Is there anything that you can say that what should be the next step there?
Yes, I mean, what I mentioned was that there needs to be other standards available. So what is the problem? Why are more apps not wanting to connect up to clinical data sets? The first challenge is that it's quite expensive for developers, and the second challenge is for the developer. It can be quite time-consuming, resource-heavy, and they don't necessarily get a benefit. So we're trying to work with system leaders to, first and foremost, make that process easier, so that the developer is able to achieve the right standards, know about the right standards, and then leverage benefits by incorporating those standards. At the minute, we don't have a value chain. So obviously what we're doing, if you think about what happens with drugs, when a drug is prescribed, there is a value chain that sits behind that process. When a healthcare professional is recommending or prescribing a health app, there is no value chain currently that sits behind it. And what we're trying to do is work with national procurement leads to set up procurement frameworks that enable that to happen. What we'll then see is a differentiation in the health app marketplace, and there will be greater value associated with those health apps that are able to interoperate within a clinical environment. And that's where we will absolutely see the big benefits. But at the moment, there is not a huge amount of incentive for all of these health apps to do that job. And so we think that we need to bring together, we call it the Pacific Ocean and the smaller oceans, and how do we bring all that data together? And by setting standards, informing the health app developer of what they need to do in a simple way, and also enabling them to have a value chain to make this worthwhile, is part of the process and the next steps for the journey.
Yeah, thank you. And what I see from our end here is that there's this tension between that the standards are very much an international market-based mechanism that's across borders by default, while the incentives are all very local or national, or at least everybody has their own incentive scheme out there, and it's very difficult to harmonize that. So it's sort of difficult to share those and to align those, I think.
There's a question here about data from the app is being collected by the vendor. Absolutely. So the question is, can we have the mechanism to send this data to the EHR and the PHR? So as for us at Orca, we don't hold that data. The data that we're able to access through an API with a growing number of health apps is, first and foremost, did the person who was recommended the app download it? Second, how frequently did they use it? Third, over what period of time? We then invite the end user, so in this instance the lady, to leave a review, and that leave a review is built like patient reported outcome measures. The lady is then advising us on her reported outcomes of the product that she used, and what we do with that information is then feed that back into our app matching capability. So if we find that women who are pregnant, age of a certain demographic, are finding certain products to be more helpful, then we can refine our app matching capability to refine the process of prescription. As for the data flow, at the moment what's happening is that health apps are doing this on a health app basis. So individual health apps are going to PHRs or EHRs and integrating data. And what we're interested in is how do we scale that? Because doing it one-on-one is a lot of work, it's very expensive, and it's not going to achieve true scale. So our ambition is to try and set the foundations to achieve that at scale.
Okay, thank you very much, Liz. Thank you very much. If someone has questions, please put them in the chat screen and we can answer them later. And I would like to go to the next presentation, which is from Richard Green from HSE Ireland. Richard, could you share your screen, or do you want me to start the presentation?
Yeah, I can. Can you hear me, first of all?
Yes, we can.
too sure why you're not seeing me, but anyway. So why can't I get it to come up? It's hiding on me. All right. So basically, we're really coming at this from a slightly different angle in terms of we're essentially an electronic health record, but some of the issues that we're going to talk about are the same issues that are to do with interoperability, etc. So this project has been a long time in place and basically is rolling out over our maternity units at the moment. So just to give you a fix on Ireland, we have about 68,000 births a year, with quite similar to most of Europe in terms of outcomes for those deliveries in perinatal mortality, etc. We have 19 maternity units, 4 large maternity units, which deliver about half that birth rate. So this project is really a change project, and we've always talked about it as that, being clinically led and IT enabled rather than an IT project. So the principles that we had when we were developing this was very much around, we do complexity in healthcare, and we're trying to simplify that as much as possible. Put the baby and the mother at the center of the care. We were looking to try and achieve a single source of truth. As far as possible, information is only collected once. We're developing an information pathway, so recording practice, maybe not deciding practice, but actually trying to help people to practice safer and in a more standard way. So that's kind of set out our principles. And essentially what we're looking at is a complete medical record with theatre anesthesia, electronic ordering, CPOE, etc. So the various phases of the project was we were essentially a paper. Nationally we were completely and still are in the units not currently on the system, a paper-based system. Some hospitals had some IT functionality around audit tools to collect information, but essentially most of the units are completely based on paper. So we started with our current workflows in paper, and then developed from there through into design and build of the IT system, looking to the future state, testing it, a lot of training, and basically it's a hard piece of work to achieve this, as it is in any change project. So I suppose our intentions were very much that we wanted to enhance clinical communication. We wanted to facilitate virtual health, enhance storage and reproduction of information, and try and assess the use of additional resources to improve care, and inevitably to get real value to try and develop a significant epidemiological database. So just in terms of improving communication, even moving from handwriting to typing has significantly enhanced that, and that's something that comes back again and again in the units that have now gone completely live. The screenshot of vitals, which already are providing visual cues and that to abnormalities, and available to multiple healthcare providers at any one time who are on the record, unlike the old days when we had one chart for vitals at the end of the bed, and unless you were at the end of the bed, you couldn't actually really assess the vitals. We've also inevitably with the electronic record significantly enhanced ordering, and one of the safety features we've already identified is around the enhanced ordering of medications, where all medications have an order sentence designed by the pharmacist, so we know we're giving the right dose the right number of times a day, etc. And we had done some research on that before and found there was significant variability in medication provision in terms of prescribing. In terms of the achieving a virtual health record, all our patients who are on the live units are now accessible to any one of us if a patient moves between units. We also have a lot of community offices providing antenatal care where our midwives go out from our hospitals, and they have full access to the record. And our general practitioners, family doctors who are also involved in this care, we have a messaging system between the maternity record and the 4 current providers of general practice or family practice systems. So our antenatal care and discharges and everything are going out with agreed information between us and the family practitioner. And some of the benefits of that have been the referral of patients to tertiary hospitals. The information is already moving. We have access to the information before the patient comes. We can sometimes decide whether a patient needs to come or not because we have the complete history available to us, unlike just getting something or trying to prize information out of somebody over the phone. You can actually review the whole record. Clinical decision support is inevitably built in. I'm not going to spend too much time on this, but we have a national modified early warning score for patients, which is the paper version on the left of the screen there, and that's been built in exactly with the same, following the same guidelines into the electronic health record. We have quite a bit of documentation that's built with education, if you like, built into it. So it kind of drives you to do the right thing. Dealing with sepsis, it pushes you down through the doing sepsis 6 and all the rest of it. So quite a bit of thinking about how do we help people do the right thing. One of the things we found in the paper record very much was drug allergies were sometimes documented, but often not, and could easily be missed by people, whereas in our current system we have built in that you can't actually prescribe unless there's allergies documented, and if you have an allergy to the drug group, you're not allowed to actually prescribe it, or at least you have to override the order. And we work fully across the whole multidisciplinary team, and this is just a quote from one of our medical social workers, stating how they find that it simplifies and concentrates most of the communications into a single interactive site. So I think that is really the benefit of building information that crosses right across the thing. One of the biggest issues we have found is that going live is one big project and a big achievement, but staying going and sustaining the change actually requires a lot of resource. And it's a significant challenge, and we thought about it, but perhaps we hadn't realized the size of that requirement. One of the things that we have are very much is on our kind of to-do list. We have been working on trying to do it is a patient portal, because previously the women attending maternity services carried their own charts and had full access to all the information, and whereas we've now reduced what they have access to, and inevitably to expand the service fully right across the community and everything, we really need a good patient portal, and that is a project that's kind of some work has been done on at this point in time. This is some feedback from the patients with respect to what they wanted, and effectively a lot of them want access to the full chart. They talked about they felt more in control when they had the information, and they definitely should have access to my notes on an online system. I liked having my green folder, which was the notes for my pregnancy, so I could look at them, taking note of my weights, etc. So inevitably, the consumer, if you like, or the patient is the one who has the greatest interest in their information and will ensure that it's accurate. And so that's an area that we feel we absolutely need to develop sooner rather than later. Some benefits, I suppose, I've touched on some already in terms of better documentation, real-time documentation, multiple user access to the same record. The MDT feedback we've talked about. We had done some audits in our own unit before we went live, in terms of times and stuff like that. And for instance, preparing a baby chart, which the midwives did while the woman was in labour normally, the estimated time for that was around 12 hours of midwifery time, completing that documentation over a day. And now it's a single press of a button, and an agreed history of the baby, which is the pregnancy history, goes across to from the mother's chart to the baby's chart, and is immediately available to the neonatologists if they need to assess it. Managing lab results was about 9.5 hours a week in our maternity clinic, and we expected to reduce that to around 3.5 hours, and that's been achieved because they have immediate access to all the lab results across the system rather than looking for paper results. I suppose one of the big interests was we have a fairly strong degree of clinical audit and reporting in maternity services in the country, and in fact a number of major national audits in perinatal mortality, maternal morbidity, planned home births, and most of the hospitals also produce records. So auditing and up-to-date reporting was something that we really felt that we could get significant benefit from. And looking at things like cesarean sections using the internationally accepted Robson classification, we have actually built that into the record. In my own unit, we were spending about 32 hours a month to identify patients and compile the reports for that kind of information. We can now do it in minutes, basically, running a report. There is some time inevitably spent on data quality to ensure that we have all the data correct, but we're reducing that significantly, even allowing for data quality checks down to probably about 10 hours. So I suppose one of the issues we can talk about systems functioning and interoperability and all the rest of it, but actually there's a real challenge to data integrity, and we have opted to look at trying to use routine data collection, picking simple raw data with clear definitions, and classification of the data is kind of secondary. It's done after the reporting stage. And really this needs to be somehow an integral part of the normal care of patients. So we need to be thinking up front, what is it we want people to collect that's really valuable for patients, but also that it's not only the systems need to be interoperable, but actually data points need to be interoperable. And it needs to be the responsibility of all clinicians as part of their work to collect appropriate data. And there's some very good work of some years back done by the London School of Hygiene and Tropical Medicine, the RCOG, that actually looked at units in the UK and basically scored them on important points of data points, including things like parity, gestational age, onset of delivery, and birth weight. And these are all things that we would expect that we'd have in 100% of cases. But they decided to fail people only if they had greater than 30% of those missing, and there was only 41% of hospitals data that actually didn't fail. So 60% failed on one or other, and I have no doubt that if I did the same study in our units, we would find exactly the same or perhaps even worse outcomes. Already we know that most of those points we can achieve 100% in the electronic record because of the way it's set up. So how does this system, which we call MNM-CMS, we don't particularly like the name, but it's the Maternal Newborn Clinical Management System. How does it help the health system? Well, effectively it begins to standardize healthcare information. It's more accurate. It gives more accurate birth registration. It allows us to look at case mix and management of resources. It's definitely beginning to help us already in terms of service planning, and I suppose in the longer term the aim is to enhance care at the individual level through robust epidemiological data. And inevitably the transition of data to actionable knowledge, and I think that this is where we begin to use the electronic health record and pulling in data perhaps from other points of information around an individual to actually assist the individual's long-term health through portals and apps, which we've already been hearing about. Thank you very much.
Thank you. Sorry, I needed to find my unmute button. Thank you, Richard, for your excellent presentation. I see a couple of questions. I got one from Laurie, who sent it to me, but I think he meant it for everyone. How is the performance of maternity hospitals made available to consumers and make processes more available?
So I don't fully understand the question. How does the system resource?
Can you copy and place it in everyone?
Well, I see that there seems to be information there around what are we using our data for. So, or how are we assessing data? Currently, we have a maternity safety statement that's produced by each hospital each month, which is being done in all hospitals, including in paper. But we can easily in the hospitals with the electronic health record, we can achieve that information very quickly. But essentially, that's actually put up on a HSE website, so it's available to anybody who wishes to look at it in terms of seeing, hospitals' outputs, how many, what's their cesarean section rate, what's their perinatal mortality. There's about 15 to 20 data points that are available to anybody who wishes to look at it. There's also a national management data set that's also produced by every hospital every month, and again made available through the National Women and Infants Health Programme. And so that's the way we're using the data, and then we're also using it nationally into the National Perinatal Epidemiology Centre and into the what's called the HPO, or the Hospital Pricing Office, who look at essentially perinatal statistics in terms of basically what's the demographic of all our patients who are delivering in our country each year and stuff like that. I don't know if that answers the question, but there are some of the places that we're using data in.
Okay, thank you. Laurie can respond later if he wants to know more. Nick also has a question. You mentioned implementation and sustainable change. What do you think are the critical success factors for change, according to the lessons you learned in that, to make the change sustainable?
Even within the hospitals, the biggest single thing that you need is you need a number of champions in the hospital for the change. You need supportive management. You need a significant amount of education, not just prior to go live, but actually where we found the problem was maintaining it in an optimization timing really after go live. You need a resource that's immediately available to spend time with people when they're working on the system for a few weeks or months to really assist them to do it. And once you do that, actually it's amazing. But we're now at a point where nobody wants to go back. We're 2 years in, but literally they don't know how to do other things. And we have quite a lot of young staff now who have never worked in any other way. So the idea of going back to paper, if we have a downtime for a couple of hours or something like that, which is uncommon, but it's a real issue for them. So I think an awful lot of it comes around to setting up to have the resource available to assist optimization afterwards.
Okay, thank you. Thank you all three presenters for your excellent stories. And I know, Richard, that you have to leave in 25 minutes. So I think I would like to go to the next part of this session, and that is to the discussion part. And here I would like to invite everyone to use the features of their of Zoom and just use the unmute yourself, use the voice if you want to share in the discussion, or use the video. Because now we're going to the more discussion part. First, I think with all three of these presentations that come from different angles, but looking at the same issues and the same problems, I one of the interesting things is what is the single most important lesson that you've learned or product that you've made or solution that you've come up with or approach that you've created that you think that could be applied outside of maternity care and could be applied in other areas of healthcare, or should be applied not just in your geographical region, but should be applied in as big a market as there is out there internationally. Anyone want to comment on that, perhaps?
Hello, Herco. It's Laurie speaking. I don't know if you can hear me.
Yes, I can.
It's Laurie from Australia, and I don't know how much people know about the Australian digital health, but the biggest challenge in interoperability and cross-border has been trying to find out where the relevant services are and being able to find them. And certainly in Australia, several years ago, we created a National Health Services Directory, which is about services. We don't care about people. And all 8 states and territory governments, so that's 8 governments, plus the federal government, so it's equivalent to the European Union, all agreed that we would have a services directory. And this enables the free flow of data, plus you put electronic identifiers. So we now have what's called the National Health Services Directory, and it now handles currently 9.5 million transactions per month, sending discharge summaries, referrals. It has consumer apps so that you can find a dentist, doctor. It's health and social care, and it's public, private, and not-for-profit. So, and it's opening hours, languages. Takes a long time to build up, but you just start with the core 4 of hospitals, pharmacies, doctors, and emergency departments, and that enables anyone with a smartphone to find what they're looking for. And I'm just wondering why everybody in the European Union and the people that I talked to were so reticent not to be able to at least look at this idea when it's been around for 6 years. And you can put that data onto, there are 400,000 services. A service is a GP or pharmacy, but then you can link programs such as diabetes to pharmacies. And you can do service planning on a major scale because you integrate, the federal government gives you census data, you then break it down into the age groups, you can then do it into disability. There is so much that you can do, but people fail to grasp. And I was just wondering if there are any, why people just don't take on, just because there's a line on the map doesn't mean that healthcare stops. Health does not stop. Healthcare does, and what is the postcode lottery, but that shouldn't be the case for any citizen wherever they are. So I was just wondering, I can show you on the screen if anybody wants to see or anything, but just very quickly, I don't want to take over the conversation, but I was just making that point about interoperability.
Yeah, if you could at least share a link or maybe several in the chat. But I'd really like to ask if other people want to comment on this. Why is it so hard to adopt something that was created elsewhere but has been very successful? Nobody?
Richard here. I think it's like an awful lot of things. You know, we all have slightly different requirements, and sometimes it requires you know, again, a change champion, somebody to actually take on something like this and actually begin to get the benefits of it. Now, maybe out of this group, maybe one of the reasons for this grouping or for this discussion this morning is to try and initiate that in a European-wide basis. Because I think unless somebody kicks it off, you know, we all burrow away in our own little places and do the best we can. But I think one of the problems that has been identified hugely as more and more information becomes available through electronic means is that, you know, all the companies and suppliers and that involved are very happy to talk about interoperability and how they can be interoperable with everybody. But the reality is it's a huge bloody process when you actually get around to trying to get them to do it. So
That wasn't good.
No, in many ways, the end users really, I think the problem has been that we haven't actually been laying down the requirements adequately at a state, government, European level or whatever as to what is it we want to achieve. And at least this process might be the beginning of that for Europe.
Yeah, one of the other things, I fully agree, but what you also see also with development, it's a not invented here syndrome, which is some of the challenges in all these processes, I believe.
Well, could I?
Not good when somebody leaves.
Okay, hold on. Unmute. Okay, sorry. I'll try once more. I was on mute still. Okay, so I think the reason why this Australian solution is probably not adopted here is that it's not the technical issues that is the problem. You don't start from the technical solutions. You start from the need of people wanting to communicate with each other. So it's in our view we have this interoperability philosophy, and you start from the organizations who want to commute and exchange information. That's, I think, also the biggest hurdle you have to overcome before you start thinking of the solutions.
Okay, thank you. I think there's and I will go to the next slide. And if we use the annotate version of the annotate function again, what we're trying to do here is find not just the solutions that are out there, but where we think that there's a common ground. And I think, Laurie, you made a very good point in saying, well, we should actually learn more from each other and not just hear what someone else has to say, but actually make yourself vulnerable by applying some of the lessons learned elsewhere, while at the same time finding a way to go through that learning curve with your within your local ecosystem, because you have to make it your own anyway. But I think there's many kinds of solutions out there in the field that everybody's been working on that could be shared with each other, like Laurie did and like our three presentations did. That I would like you to use the annotate version and use the text or draw or whatever to indicate that you have a working solution somewhere that you think could be applied either elsewhere in healthcare outside of maternity and baby care, or at a different scale internationally. So this is our to-do list to look into for the next couple of sessions, I think.
Okay.
Okay, you can use the chat function as well if you want. That's no problem. From the ministry, I would like to comment on the tension, the comment about the tension between regulation and innovation. Because we hear that a lot. We heard the same with the GDPR, and now the medical device regulation, and there's other regulations out there from at a European level, but also at national levels. And of course, this is true. So it's not that I'm going to sugarcoat it or say that it's not true, but it is true. And I recently went to a presentation sort of like a TEDx talk by an IEEE fellow who's the IBM head for AI and Internet of Things of their lab. And he's also an IEEE fellow. So he's very much involved in standards regulation and creation. And he said something that I found was very valuable in this sense, is that currently with all this exponential technology, we're at the crossroads where technology could either shape society or society could shape technology. And this is what I think is the core of this tension between regulation and innovation, because standards and regulation, well, standards more than regulation, because standards is less has a shorter life cycle than regulation normally. But since standards translate the societal values into the requirements set to technology, so standards that we make and the regulatory constraints that we put on technology are not about limiting growth or limiting use, or so there are constraints put there that translate the values of trust and safety and security into the way that technology should use them for society, well, a meaningful way. At least that's how standards should be used. So I do think that there is an important tension there, and I welcome the tension, because that means we can have very good and focused discussions on how we feel that society should shape technology and not the other way around, and where we want technology to shape society because of all these innovations and freedoms that it brings. And I think that's a part of the discussion that's there, and that it needs to be at all levels of this model that this discussion takes place. Okay, is anyone there who wants to highlight their comments, because it's starting to get more difficult to read through all these, but we're saving this, so don't worry. That means that everything is stored. But is someone there who wants to explain their comment?
Yeah, well, I added the word detailed clinical models there for the maternity care. I think that would be useful to exchange across the various parties internationally, because I think it's something which we have in common. I cannot imagine that for maternity care in Netherlands we would have other data which is important than in other countries like Australia or UK or whatever. And we see, of course, in these commonalities is that we try to reinvent the wheel. We are trying to search which terminologies, which value sets would be useful. And I think if we, exchange this information throughout the countries, we could help each other understanding what SNOMED codes or what line codes are used in other countries and so on. So that might be a useful tip.
This brings me to a wish that we defined at the start of the whole task force, actually. Because we started with the coalition of the doing, so people showing what they are already doing and then seeing if we can find the common ground in that. And this is a big part of that. But can we come to a list of standards at these different levels And so we could even have policies and different regulations that are there in all these countries that we have in common, that we may have different implementations of, but at least that we have in common. And then what we want to do is propose this list. So we create this list, and then we propose it to the authorities that are out there. And then we make it as authoritative as we can, because all the incentives and the requirements need to be followed through in every country or at every different level. So something should be done by the European Commission in their work for the new exchange format for digital or electronic health records, for instance. We could do something with a Trillium program with the US. We could use the Global Digital Health Partnership, which is the digital health authorities of, I think now 27 countries or 23, including Australia, Laurie, and several European countries as well, and the US and India and Saudi Arabia and some others. So we can have this list that everybody agrees on from the practice, like we're in this session today, and then make it as authoritative as we can. And that way we can send a clear signal to the market as well as the professionals that you don't have to reinvent the wheel. This is the design specs, or at least part of the design specs for the wheel, and use it to your benefit. And so let's lower the barrier on actually learning and up not the barrier, but up the incentive and the requirement that you should learn. So could we do that? Is that one of the next steps that we can take?
Herco, Richard here. I'm just going to drop off, but I would agree with. I think that's a reasonable place to start. I think Laurie has been on the chat there suggesting that we look at something on the smaller side, some small steps initially, some agreement around certain things, and I think that's probably the some of the places to go. So I would be supportive of that. So my apologies, I have to leave you now.
Oh, thank you very much for your very, very helpful contribution. So I propose for the next step, because I've saved these contributions, so I can clear all the drawings. So that's one. So I will in the report of this session we will add an action requesting that everybody send in the standards that they're using at these different levels that they think that could be shared internationally, and we will come up with a proposal in how to make this as authoritative as we can. So it's not just in another document that has been published somewhere, but that it becomes a meaningful reference in as many different authoritative places as we can get it. And I think we have the networks for that, so that will really help. But I think that's a great outcome of this session already. Next, I want to talk about what are the challenges that we see, and I think Nick is going to come with this one as well, because we see a lot of technical solutions that are already out there and that are successful, but the challenges are mostly in getting them to work in practice, and that's change management, that's culture, that's soft skills, that is finding the right champions, that is all these things. So how can we come up with solutions for that we can share with each other within this group, and that we can maybe create an action on? So again, here with the annotation and the chat functions, please come up with your contributions for this. What is the next step here? So who wrote the Define an International Action Plan? Okay, that's here at the table. So I'd like to see who should be the first to take this up.
Well, you have to mute. Yeah. Well, I looked at the way we did in Netherlands. We also had an outcome plan from Erik Gerritsen, where he said, okay, in 2020, I want to achieve this or that. So we could do that, see whether we have felt any followers on the international ground to see if we can achieve something similar internationally, like we want to have a higher quality of services or whatever for maternity care in 2025 or something like that, see what the elements below that should be, lower mortality and so on and so on and so on. So that was the thought, is see if we can get people involved and supporting this action plan.
Thank you. Nick, you said something very interesting in the chat that we should focus on the service aspect and redesign for change rather than use technology as the main driver. That certainly resonates, but could you explain that more?
Can you hear me?
Yes, we can.
Okay, very good. Yeah. Well, I think if you look to the different experiences in countries, in the Netherlands also related to change and implementation of technology, then, well, maybe on a rough estimate, but maybe about 25% is about technicalities related to technology implementation and adaptation, but about 75% is more with social factors related to how people do communicate, collaborate, have interests in the existing way on how they work, the type of position they have, the related finances. So if you want to start to change, so it's really good to look at the broader picture on what makes people do the way they do. And yeah, there are numerous factors I think related to this. And you can probably develop some strategies, policies to change this, also regarding to finances. But then the next question is, okay, if we have to work differently, because we have to do it, but also because technology enables us, then is the question, okay, how can we do this? And then you start about, well, a discussion about redesign of services. So I think the implication is also, if you start with the existing way of how people work and you use that as a sort of starting point for technology to enable, I think you already start with some problems. Well, if you already start with discussing, okay, what are the types of improvements from a service collaboration perspective, and you provide also sort of discussion, okay, how can we enable this from many other aspects, but also the technology. So I think you can't separate the discussion about technology integration, implementation, and adaptation and related interoperability from redesigning services. And I think if you talk to different professionals, they are mainly interested in, besides the interest they have, but if you're talking really about content-wise on how they work, it's about, I want to work more efficiently, better communicate. A lot of administration work and load should be reduced. So these are the things they're telling us, and they are not talking about interoperability or the technical stuff. So I think it's really important that we look at these more functional aspects and see how we can redesign the services and try to combine this with how can we integrate technology. And I think another thing I will want to add to this is that if technology and the whole discussion with registration and transparency is seen as a sort of consequence, the consequence is more administration, is more workload. Even the resistance to adopt technology will be more higher. So I think we also have to frame a little bit the discussion and make it more the sort of effort. How can we improve healthcare, redesign it, and combine efficiency, etc., with this more technology implementation?
Okay, thank you. I think that you made some very valuable points there. I would like to point out that this is the a session held in the for the first task force on interoperability. There are 3 other task forces in the Digital Health Society, and task force 4 is about digital transformation and change management in health and social care organizations. So it actually focuses on a toolbox or a set of tools for healthcare professionals to deal with the transformation part. So maybe, I think that underlines your point that it is very important and that we need to set next steps in this. And in view of the time, I also want to go to the next steps. And I think we have, because I think we all agree with what you say is important. And what I'm looking for now is what is the consequence of us thinking that this is important, in the sense of, do we need something we don't have yet to bring the change management part to the interoperability challenges that we face? Or do we need to provide input for Task Force 4? Or is there something that we need to explore more in a different session later on? And maybe we can have some tips or examples on how to proceed on that.
Well, I think it's fundamentally wrong to think that interoperability is very different or not connected to the functional requirements of professionals. Of course, they are related, and it's also discussed. But if you're really looking at how the IT architects and IT managers in hospitals, they only talking about use case in terms of data protocols, about uniform language. And this is totally true. But if it's not connected to functional requirements of professionals, this will seen this whole discussion, and also in the Netherlands, there's so much dominance about this use case approach in terms of uniform in language, which is totally not of interest of professionals. And they also seen this, like registries, outcomes indicators, are seen as this will create a huge administration burden. Well, it won't help me with working more efficiently, etc. And so there is something critically lacking between the connection between these more functional requirements and the whole discussion, how do you create interoperability? And I think that's a strategy risk. So I think it should be really on the table. And also, we studied some use cases for the National Institute for Healthcare. And this was one of the conclusions, that these more functional requirements, and take this as a sort of starting point to work down the interoperability aspect, is, I think, not yet so successful. It should be rather the other way around. It should not be separate also from discussion on lean management, on integration, because if you make separate these discussion about we have to integrate services from a medical point of view or a service point of view, or we have to work on more lean management and efficiency. If you separate this whole discussion about this enormous challenge on how to redesign services from the interoperability aspect, it will not be understood. And also you don't gain the interest and commitment of professional groups.
I fully agree with this. And we have on the table a very great example. We shared the maternity and baby care, where we have the whole process from the use case, from the professionals, from the patient. So from the really where it comes all together at the individual and the care team into what do we need. So technology follows functional needs. And I believe if we continue like we do now with looking at use cases, looking at over across borders, and try to find, for example, for this particular use case, what are the best things working in the Netherlands, in Ireland, in Australia. So what can we, what's match? What are the best things we can share with each other? What we're now doing, but then take it one step further into practice.
Okay, thank you. I think this is a very, very interesting discussion, and here at the table there's a lot of agreement with the points that are being made. So that brings me to, I think, the final part of this this session is I would like to ask you two things. One is what is your takeaway? What is your takeaway from this session? So, what kind of concrete or inspiration or example is something that you want to look into more after this session? And please add that to the chat. Because the other question is what is going to be how are we going to take this discussion to the next level? The Dutch Ministry of Health has been leading this task force since its inception in 2017. And to be honest, no, I'm not mute. Oh, okay. Can you hear me?
Ziet eruit alsof je mute bent. Niet meer. Die stond net zo, niet meer.
Okay, now everybody can hear me, I think. But so we're looking at the next step now. The next step in what do we take away from this that we need to continue, and the other thing is, so that's our agenda for the next step in whatever form it takes. And the other thing is the form of the next step. Do we do another of these sessions? Do we use a conference where we have a part of the ecosystem already together and organize a session there? Do we write a white paper, and who will help contribute to that to take this to the next level? Because the Ministry of Health has been leading this task force since its inception in 2017. And to be honest, the topic of interoperability and the discussions that we're having are very, very interesting. But it's very difficult to go from those discussions to taking a Okay.
Yeah.
I don't know what happened, but somehow Zoom crashed on me or restarted, or so that's probably why everybody couldn't hear me. So again, this next steps. So again, we are looking at the form and the agenda. So if anyone wants to comment on the form, will it be another of these Zoom sessions, and who will organize it? Who's willing to step up and say, okay, I will do that? And Federica and Valentina from the ECH Alliance have been very supportive for us in organizing this, so I'm sure that they'll be happy to support anyone else. Because I don't think this is necessarily a ministry-led initiative. This is a discussion that involves everyone, so we're very happy to have other people participating in this discussion as well. We will, of course, make a report of this session and then share that with everyone and publish it on the Digital Health Society website. yeah, what kind of form would you like to have the next step in, and what is the concrete agenda? So I already have the list that we're going to make of standards used in maternity care that are international enough to see if we can come to a common list and then make that as authoritative as we can. But the discussions that we just had are very interesting, and we need some way to continue them and for something to come out of that we all can use. So anyone want to comment on that?
Yes, Herco, could we make a list from what we learned today with each other? What are the things we are going to look further into more detail to use, for example, for the Netherlands, but in a way that we can use it for Europe? So we already have our maternity and baby care, our Baby Connect program. Are there any things we heard today that we probably can use in our program? And then if we make it practical, we can share it in our next meeting and see what are critical questions come up. So we think through it very well, what we heard today, because it was a very valuable, excellent meeting. Thank you for this.
It's Laurie here. I was just wondering, there's certainly a very
I'd like to respond to that. I think that's an excellent idea. I think it's nice also not only to worry about how to push our knowledge or share our knowledge and what we have with others, but also see, okay, what are we harvesting from this? And from my point of view, I agree with you, Marlene, that we heard some very, very valuable things that we can definitely look at and see how can we include it. Earlier on, I already had contact with Liz a year ago about Orca, for example, but also from the other presentation and from the discussion, I heard quite a few things, and other people here at the table as well, I think, that we can look into and see, okay, where does it fit into our approach and the methods we use and in the roadmap. So yes, I think that's a very good suggestion to do that, and also to share then with others, okay, this is what we picked up from it. So that we can share also the results of a session like this.
Laurie here. One thing I did learn from Liz's presentation was that the requirement for what I would call lift and shift, being able to take from one country to another quickly and easily. And I would suggest that you start with the basics, which everyone requires, so that we can actually show benefit very quickly and agile, instead of sorry, but I'm a man of action, or GST, get stuff done. And you know, healthcare is 20 years, 10 years behind every other industry sector. Just my thoughts.
We completely agree. So here's what I propose. Together with Valentina and Federica, we are going to make a report of this session. The recording of this session will be published and made available, of course. But I do think that there is a lot more that we can do together other than read a report. And I don't know about you, but I don't revisit the session that I participated in a lot. But I do think there's a lot of things that we can still share. The Digital Health Society website has a platform where we can share, and we will make sure that the report has something in that. And the report will also come up with a to-do list, a very practical, easy to use to-do list that you can sign up for these different actions. And you can add actions to that as well. But I agree with Laurie that getting things done is very important. And I also believe in keeping it simple. I'm not pronouncing the second S here. But yeah, keeping it simple. So maybe something like a to-do list and with a name behind it that is going to drive that manageable action, and a suggestion or well, maybe as far as we can get it, a proposal for the form. And this could be, like I said, it could be another Zoom session. These are very easy to set up. So that could be it. We could do an online discussion in the platform. We could organize a session at a conference. We could, well, there's many different forms that this can take. So let's not be hung up on all these different forms, but add a form to the actions that is appropriate. And I think if we do that, we can keep it manageable, not something that will include everyone and everything and needs to solve everything for everyone. Because that's, in my opinion, that's one of the dangers of discussing interoperability, because it links with everything by definition. And it's linked to everything by definition, so it has dependencies on everyone and everything. So it's very difficult to come up with strategies and actions that will take manageable steps further. But I think with this group we have a very distinct chance of actually doing that. So with that, I would like to thank everyone. We've made the 2.5 hours full already, so I think that's a testament in the fact that it is a discussion that needs to be going on internationally and within the whole ecosystem. So thank you, everyone. Thank you especially for the speakers. Liz and Richard have already left, but I will make sure they get their thanks in person. And thank you as well for Doreen, who's sitting here in the room with us. And thank you everyone for participating. And I'll leave it open with anyone who wants to come up with the final bombshell of this session.
It's Laurie speaking. Just like to say that you've done an excellent job, and I think these are very useful in getting people from different time zones to be able to give and exchange ideas and learn from each other. I would suggest that you do small, well, practice agile, which is small, quick steps. Don't take big steps in large amounts of money, because we all know they're doomed to failure. Just something that shows value quick in weeks. I say in weeks, such as startups do, instead of going to the big companies and spending hundreds of millions over years, and their technology or whatever is out of date before you even start. Anyway, sorry, I've just seen it all before, so just my views. Thank you very much, Hiroko. You've done a brilliant job, and to the organizers.
Thank you for sharing your experience, because that's very important, I think. Okay, then with that, I'm going to end this meeting, and we will be in touch with you all very soon. Thank you all.